So good
Dr.
evening.
Bide, you can
Yeah,
open the meeting, please.
yeah. Good evening, everybody. Welcome to the Journal Club meeting of Maharashtra Ophthalmological Society and BOA. And today we have a very interesting article which will be discussed. And it's the incidence of retinal detachment after cataract surgery. And I'm really thankful to Dr. Neeraj Israni and Zain Khatib for taking active participation in this Journal Club meeting. And I would like to thank Dr. Vaishal and Dr. Parul who are very enthusiastically conducting this meeting every second month. And without wasting time, I would request Dr. Vaishal to start the meeting and introduce the speaker.
Welcome everyone, and yet another meeting of Journal Club. And the basic purpose of the Journal Club meeting is to uh, enable the postgraduates to understand how the Journal Club presentations are done, and to get from the faculty the take-home messages. And this activity has been slightly modified in this meeting, where we are now having virtual certificates. At the end of the session, the virtual link would be enabled in the registration link next to it. So you can get your virtual certificates downloaded. And without further ado, I hand over the session to Dr. Parul to take it forward.
Thank you, Dr. Vaishal. I would like to introduce our panelists for today. So we have Dr. V.C. Mehta, who's a renowned cataract and refractive surgeon practicing in Mumbai, in Ghatkopar area. I think he does not need any introduction. An excellent surgeon. Then we have Dr. Nazimul Hussain, who is a well-known vitreoretinal surgeon. He's currently practicing in Dubai as a head of the department and the vitreoretinal surgery department. He has done his undergraduation and post-graduation from Guwahati, followed by his retina fellowship from LV Prasad Eye Institute. Then he has worked in LV Prasad and in Mumbai also as a vitreoretina surgeon. So welcome, Dr. Nazimul. It's nice to have you here on this platform.
Thank you for
Our
your
third
invitation.
panelist is Dr. Shail Vasavada. He also does not need any introduction, but he is currently practicing as a cataract and refractive surgeon at Raghudeep Eye Clinic at Ahmedabad. He's done his graduation from Ahmedabad, followed by his fellowship at Raghudeep Eye Clinic and LV Prasad Eye Institute. He has a lot of publications, and he also has received variety of awards, the video and the best paper awards at ASCRS and ESCRS. So welcome, Dr. Shail Vasavada. And with this, I would ask Dr. Charuta to introduce our PG and take it forward. And also we have our statistical expert, who is Dr.
Sabyasachi.
Ken Gupta, and he'll be joining soon. Yeah. Charuta, over to you.
Thank you, Bide sir and Kenya sir and Parul Deshpande madam. Can you hear me?
Yeah, very well.
Yes, we can hear you.
So I am very happy to be here today with I'm Dr. Charuta Mandke from Hindu Hriday Samrat Balasaheb Thackeray Medical College and Dr. R.N. Cooper Hospital. This is the fourth municipal medical college in Mumbai and the newest one. And this is our first, sorry?
Go ahead.
Our first PG student, Dr. Monica Shahare, will be presenting today's journal club article. So she's in her second year right now, and she shows a real zeal for the subject, and is already seems to be gearing up to be a great surgeon. So Monica, you can start with your journal club presentation.
Thank you, ma'am.
Monica, just 1 second. I just forgot to introduce Dr. Neeraj Israni and Dr. Zain Khatib, going to co-moderate this session this time for the first time, along with Dr. Charuta Mandke and me. Yeah, so welcome them also. Yeah.
Thank you.
Monica, go ahead.
Yes. Good evening, esteemed panelists and everyone present here. I'm Dr. Monica Shahare, Junior Resident in Dr. Cooper Hospital, Department of Ophthalmology, and I will be discussing today's general topic club under the guidance of Dr. Charuta Manke, Head of Department of Ophthalmology, Dr. R.N. Cooper Hospital, Mumbai. And I'm very grateful for this opportunity given by MOS and BOA.
Is this your PPT?
Yeah, yes, ma'am. Yes, sir. Actually, it's stuck.
Maybe you can stop sharing and start again. That will
Yes,
help.
yes, sir.
Monica, there's an arrow at the bottom left, which you have to click for the next slide.
Yes, sir.
Yes.
Okay. So, good evening, all. Today's general topic: the incidence, risk factors, and impact of age on retinal detachment following cataract surgery in France. A national population study was published in Hall Open Science on 4th of September 2015 by Vincent Dye et al. With impact factor of 3.653. The purpose of study was to assess the incidence, risk factors, and impact of age on retinal detachment following cataract surgery. Secondary objective was to estimate risk reduction of retinal detachment by year of delay in cataract surgery. Introduction. Retinal detachment is separation of neurosensory layer of retina from the pigment epithelial layer. Retinal detachment is a vision-threatening condition. Retinal detachment is a well-known and serious complication following cataract surgery. Cataract surgery is commonly performed in people more than 65 years. Predisposing factors in pathogenesis of RD, presence of posterior vitreous detachment, high myopia, history of ocular surgery, history of trauma, predisposing peripheral retinal lesion. Materials and methods were used in the study. Study design was a retrospective cohort study. Study duration was of 4 years from 2009 to 2012. Study location. These all data were collected from a PMSI database, a national database in France. Total of 17,87,021 patients underwent cataract surgery, and among them, 11,424 developed retinal detachment after cataract surgery. These are the following are the PMSI code and ICD-10 codes were used in the study. The BFGA are the PMSI codes, while the H and S stand for the ICD-10 codes. Inclusion criteria: patients more than 40 years of age and patients who underwent cataract surgery in France were included in the study. Exclusion criteria: history of vitrectomy prior to cataract surgery. Clinical evaluation: phacoemulsification and manual extracapsular extraction were included in the study. The study also includes the patients in whom posterior capsular rupture happened and those treated with vitrectomy. Statistical analysis: Cox proportional hazard regression model was used to analyze risk factors of retinal detachment. Kaplan-Meier analysis to assess cumulative probability of retinal detachment. Crude hazard ratio was calculated for each risk factors. Adjusted hazard ratio was used to detect independent relationship between each risk factors and occurrence of retinal detachment after cataract surgery. Cox proportional testing age myopia interaction was assessed to see effect of joint exposure to young age and myopia. Log rank test was investigated for differences between age groups. Odd ratio was calculated and was of 3.87. The 4-year risk of retinal detachment in the French population was higher for older than younger adults. And we can see in this table, the ratio was increased with age. They also calculated the multi-adjusted hazard ratio for myopic and non-myopic patients. And we can see in the myopic patient, the age group of 40 to 54 years having the highest multi-adjusted hazard ratio. Results. The study gives us the pseudophakic RD risk of 0.99%. Median number of days is 237 days between the cataract surgery and onset of pseudophakic RD. They have also calculated the cumulative probability. In the first year, it was of 0.43%, second year, 0.66%, third year, 0.84%, and fourth year, 0.99%. And we can see with the each year. In the fourth year, it is the highest of 0.99%. This is the graph, the relationship between the age and the time after cataract surgery. And we can see the age group of 40 to 54 years with or without risk factors having the highest risk for retinal detachment after cataract surgery. This is the another we can see this is a relationship between the time after cataract surgery and the various risk factors they have assessed. And we can see the history of high myopia having the highest risk. This is the relationship between age and the risk of retinal detachment with the previous cataract surgery and in French population. And we have earlier discussed in the general French population, the retinal detachment risk is more in the older age, while the retinal detachment with previous cataract surgery, the young age group having the highest risk. They have also calculated and they have given us the hierarchy of risk factors. The high myopia is of having the highest risk. Then young age, extracapsular extraction technique, eye trauma, perioperative capsular rupture, male gender, and diabetes. Discussion. A study in Western Australia gives us the pseudophakic rate of 0.7%. The study in Singapore gives pseudophakic rate of 0.16%. Study in Denmark says that there is a fourfold risk for retinal detachment. It is associated with the cataract surgery. Then Moorfields Eye Hospitals says that there is a 75% of RD in the first 2 years of postoperative period. Study in Sweden says there is a 10 times risk for retinal detachment in the capsular complication. Study in the Minnesota, USA says there is no difference in extracapsular extraction and the phacoemulsification. Review of literature. These are the various studies were conducted in past. The pseudophakic rate given in the Acta Ophthalmologica gives us a rate of 0.51%, and the Royal Colleges of Ophthalmologists gives the rate of 0.36 to 2.9%, and the journal Curious gives us 3.3%. They have also calculated and given us the various high risk factors and the patient at high risk in the journal Acta Ophthalmologica, men less than 60 years of age. They have also calculated and give us the relationship of axial length with the retinal detachment, and the axial length of more than 25 mm are having the high risk. In the Royal College of Ophthalmologists gives us the various risk factors, and intraoperative vitreous loss has the highest risk, and increasing axial length, younger age, male sex, and training operating surgeon. In the journal Curious gives us the various risk factors, the intraoperative posterior capsular rupture having the highest risk with zonular dehiscence, corneal trauma, and anterior vitrectomy. In the study, the diabetes, glaucoma, and pseudoexfoliation had no impact on RD, while the Royal College of Ophthalmology says the increasing age is protective, and in the Curious, they have said the average age was 63 years and 47.7% were the male. The PCR found in 2.01% in the RD patient, while they have said increased incidence of RD decreases with the age, and in this table we can see the incidence was decreasing with the age and having the high incidence in the less than 60 years. While the Royal College of Ophthalmology has given us the phacoemulsification has similar or lower RD incidence than extracapsular extraction, and also says that the RD rate drops about 0.1 to 0.2% per year. The strength and limitation of study. Strength of study, large population size. Limitation of study. Preoperatively, no retina status was mentioned. No exclusion of surgeries other than vitrectomy. Take home message. Preoperatively, full retinal examination should be done to rule out any pre-existing condition for RD. Extra care should be taken in young patient and myope patient. Mari effect, method, study question, well-defined. Study population was appropriate. Study period was well-defined. It is a retrospective cohort study. Assignment, matched for the baseline parameters. Male to female distribution not mentioned. Assessment, measures of outcome was appropriate. Level of training of surgeons not mentioned. Results, statistical tests performed and are appropriate. Chi-square test can also be applied. Interpretation, p-value assessed and it was found to be significant. Mechanism of RD in young myopes not analyzed. Extrapolation, due to large sample size, the result can be considered in our practice, emphasizing on the preoperative retinal status evaluation and extra care in those who was at high risk. Thank you.
Thank you very much, Monica, for excellent presentation.
Thank you,
Um,
ma'am.
And I'm glad you also have mentioned properly what the limitations are. Going into depth of the review of literature, which you have done separately over and above what was in the journal with the help of our teachers
Yes,
during your preparation. So now I'll hand over to Parul, madam.
Yeah, thanks, Charuta. So I would like to first ask Dr. Nazimul about his opinion about this article and his views as far as the results are concerned. Dr. Nazimul?
Yeah, so this is a little bit old, but the most important what I felt when I read through the journal is that any registry study, just like the one which was published in Minnesota, any registry study defines what is the real life situations, and that is why we do such kind of cohort study. This study cannot define many subgroup analytic results, which is not possible because the cohort is so huge, but it can send a message. I feel the most important message that this registry study has shown that younger age group, and this is the only study which I found less than 40, between 40 to 50 years, if you do, the risk of retinal detachment increases, and that implies that the vitreous is still intact in more or less in most of the patients. And that is why as the age grows, the vitreous gel degenerates and there is a posterior vitreous detachment. So whether you do a phacoemulsification or you have the posterior capsule rupture, which is toilet well, the risk reduces. So the important message for me right now, suppose in the country where I stay, young people undergo a lot of cataract surgery, both in terms of refractive lens extraction, as well as nutritional deficiency, undergoing bariatric surgery, getting posterior capsular opacification at the younger age. So the incidence has increased of cataract surgery in whatever is the cause in the younger people. When I say younger, is less than 50 years. So this study has given me a confidence to discuss with my patient while taking a consent that there is a risk. Okay. So, and this is very important part of all these registry study, that you can inform your patient the risk because it's over time and it's a huge cohort of patients. So there is more value to this study. So here I find for me, less than 50 years of patient is a very important information. Okay. So this, and it is well presented and you have selected a very good article. I think it's very important for most of the cataract specialists over here who is practicing to understand this study, to put in their consent and discuss counseling, so you can understand to follow these patients over time with the risk. And of course, rest are all theory, which we know for long. You understand? But what we imply now, I want to add one more literature which I reviewed about 6 months back from US. So that study is also good. It's very important to do if you have a PVD in one eye and you develop retinal detachment, the other eye and has a cataract and you want to do a cataract surgery, it's very important to do in all cataract patients a preoperative optical coherence tomography to understand the vitreous relation to the fovea. If there is a partial vitreous separation, that there is a chance that these patients might develop further liquefaction and somewhere unknown adhesions can cause a tear because of risk in one eye which already has a retinal detachment. So I think preoperative, as Monica has already told, a proper retinal evaluation, understanding the vitreous body is important, and besides other peripheral retinal degeneration. So I think this is from my side. If there is any question, we can discuss further.
Yeah, thank you, Nazimul. So Charuta?
I think Dr. Sabyasachi Sengupta is still to join. We'll be calling him.
He'll be joining after some
In the
time.
meanwhile, if I can request Dr. Zain Khatib to ask a few questions to our panelists, the other panelists as well. We have few questions which we have listed down.
So I think
Yeah.
two things which I found, 2-3 things that I found from the article were, one is that all of us as clinicians have this clinical impression in our mind that, young patients, myopes, have a higher risk of retinal detachment, and therefore, we are very skeptical in advising clear lens extraction and things like that for extreme high myopes, particularly in younger age groups. So this study sort of gives us, sort of exemplifies our clinical thought process in terms of actual data and actual literature to say that. Like preoperative retinal examination is important. An important take-home message for me would be that in such high-risk groups, it's important to have the retinal surgeon have a look at it post-operatively also, because PVD tends to occur typically between 4 weeks to 3 months after a cataract surgery event has occurred, if it has to occur. And therefore, it's important that a retinal surgeon has a look at the periphery of the retina again after 4, 6, 8 weeks to reassure us and to reassure the patient that if any event or any break event has started, it can be lasered quickly before it develops into a full-blown retinal detachment. Now, when we actually look at the study, although it's a huge data and it has great numbers, there are few things that we look at when we sort of look at this data. One is, it's 2009 to 2012 cataract surgery is performed during this period. So naturally, the patients having cataract surgery in 2009 are more likely to have 3-year follow-ups compared to a person who has had cataract surgery in 2012. Because they mentioned in the article that they've taken the last follow-up somewhere in 2012. So that would mean that patients operated in the later half of the time period for cataract surgery are likely to have lesser follow-up period in their follow-up. Second, it would be also important to know whether it is all the patients who had been operated during this time who have had this follow-up, or some patients never had some follow-ups, and only those that had follow-ups were selected into this database. Because it is quite likely that patients who are quite okay or quite good after cataract surgery, or sometimes they may not turn up for follow-up, they may not be in the particular region or to get registered in the registry. So that is also one point that statisticians look at when they analyze the data, that are these consecutive patients who were operated and their consecutive follow-ups, or they were selected from a selective cohort who had the follow-ups registered in them. That also makes a statistical analysis a little different. And the third reason would be there's no definition mentioned from what I could read in the article about what is high myopia. Because high myopia is defined very, very differently across all groups. Some suggest 25 axial length, some suggest 26, 26.5. So it's important to know what is high myopia defined as.
I think they said 26.
26, yeah.
Okay.
They said.
Dr. VC,
26.
if we can have your opinion about this article.
Sir?
Sir, unmute yourself, sir. Sir, unmute.
Sir,
You can unmute. I think Rahul can.
VC Mehta,
Rahul,
sir,
if
you
you
need
can
to
unmute.
Rahul, can you unmute? Dr.
Rahul,
VC?
can you unmute, sir?
Yeah, he's.
We'll have to call, sir.
He's trying, but he's not able to do it.
Meanwhile, Dr. Shell, I would like to ask you your thoughts on one thing. So I know that your group has been popularizing the pars plana vitrectomy in case of a PC rupture versus the limbal route. So do you feel that doing the vitrectomy from pars plana has an effect in reducing the risk of detachment, or do you have any evidence to back something like this?
So no, that it would be very, very difficult to produce an evidence in a PCR situation to have evidence of limbal versus pars plana. Whatever approach that we use, I think let's leave the approach aside whether it's limbal or pars plana. The important thing is to address the vitreous before you do the next step. Say, for example, you feel if there's just one strand coming at the side port, first let me remove the cortex, first let me remove the fragment before I do the vitrectomy. That maneuvering is what causes traction from where the attachment of the vitreous is coming from. So the most important message is whatever route you use, limbal, pars plana, make sure you tackle the vitreous first the moment you encounter it before doing any other maneuvers going forward. So I think cutting the attachment from where it is coming from will help to reduce the chances of traction and traction induced breaks.
Nazimul, what is your opinion about that? What Dr. Shell said?
So I tell my colleagues here, if they at all have it, so if you have a vitreous loss because of posterior capsule rupture, so I think what you need to assess on the table, I tell them to see how much the vitreous has prolapsed into the anterior chamber. So you need to visualize that, and they try to see the vitreous by staining it. So if it is just humping on the posterior capsule and little bit prolapse on the anterior chamber, I think a good anterior chamber toilet, if it is done properly on the behind the posterior capsule as well, and to see that the vitreous has gone back, then it's okay. But if you have not been able to completely toilet just behind the posterior capsule as well, then probably what Sahil has told, that you should go from the pars plana and remove the anterior vitreous so that it falls back. So none of the vitreous should not adhere even to the zonules or to the posterior capsule, even though the rupture area is clear. And these are small intricacies that if you understand microscopically, later on it can give problem on the peripheral retina. So having said that, the most logical approach for any anterior segment is to do a good toilet. And if they are not confident on what I said, then they can, if they're comfortable, then they can use either 27, 25 to clean it from the back or call their colleagues. So idea is to address the problem, that is the vitreous. In retinal detachment, the problem is vitreous. So if you understand that physiology and the pathophysiology of problem of the vitreous, I think you can address it well. So I think nowadays most of our cataract surgeons are well trained, and they rarely call me. So it's like once in a blue moon I go. So that means things have improved.
So if I can add one more point, Dr. Vasavada and their group have studied on the vitreodonesis because related to the phaco turbulence. So I would go a step ahead and say that the amount of turbulence created during the phacoemulsification or during any cataract extraction surgery, the decompression of the eye occurring, that would induce PVDs more. I think Sahil would elaborate it this point more further and emphasize it more further.
Yeah, so we did a study which we published last year in IGO, where we did a cadaver eye experiment and we injected triamcinolone in the Berger space with an intact capsule. And we just went from foot position 0 to 1, 0 to 1, 0 to 1, and kept increasing the bottle height and kept increasing the flow rate. And what we found was that just the trampolining of going from 0 to 1, 0 to 1 led to a rupture of the anterior hyaloid, and we had triamcinolone particles transmitting right up to the posterior vitreous. So even your fluidic parameters, particularly in such high myopes or special eyes, be careful about it, lower the better.
So your study validates, I think this is a wonderful thing he has said. And this study gives to the anterior segment an understanding of the vitreous body. Okay. And that is why this study also, his finding, Sahil's finding, validates what is found in this registry study. So that is why as the age increases, your vitreous undergoes more liquefaction and more separation. So less chance of, if at all there is a separation, there is a traction, you would have developed a tear before. And if you do in the elderly age group, that's why the incidence of retinal detachment post-cataract is less. So the cumulative incidence increases as the years are younger, and when the gel is more formed and there is partial detachment, So these donations probably will come. That's why I say the last study which I evaluated, why studying the posterior vitreous is attachment to the retina is so important. And those eyes develop retinal detachment later, or tear rather.
Thanks. Do we have Dr. Mehta? Can you hear us? Dr. VC Mehta? We need your comments, sir.
I'll ask him to call from another phone and talk to us.
Okay.
Meantime, we can move forward.
Yeah, I think.
Yeah.
In the meanwhile, we have Dr. Sabyasachi sir also, who has just joined. Before we ask few more questions about the clinical aspect, can we just have his views on the statistical aspects of the study?
And even on the retinal aspect, because
he's a retinal surgeon himself.
Hi everyone, good evening. So sorry I was a little late and haven't caught a lot of the comments that was said before. A couple of things from the statistical aspect. First is, if you look at when they are not really statistical, it's just the study design. So if you look at the inclusion is from 2009 to 2012, but then, so the last study point of follow-up is also December 2012. I don't know whether this has been discussed, but so if you have somebody who's operated in August of 2012, then you haven't given him enough time at all. So when you look at this, so how do you know how many were operated in 2009, how many were operated in 2012? So actually so if I could just quickly add, share my screen, I wanted to show you the Kaplan-Meier curve. Yeah, so how we know that is by something which is entirely missing in this, so these are these Kaplan-Meier curves. So what this really means is this risk of retinal detachment is like 0.5% at 1 month, and say it is 1.5% at 13 months, and then it increases to say 3% at 36 months or so. However, at below this, what most good papers will give is numbers at risk. So how many were at risk at 12 months? How many were at risk at 24 months? And the number will be significantly lesser, right? That's because everybody wouldn't have been followed up by that time. So you can't really say that this is like a 4-year study at all, right? Because some would have followed up for like the whole 4 years, but a lot of them would have followed up for significantly lesser amounts of time, right? So I think that is a very important miss, which has not been given here and probably not been seen by the reviewers either. The second thing is, so they also should provide confidence intervals around these numbers. Say this is 2% risk at say 20 months, and it is like a 3.5% risk at say 42 months. However, so that doesn't apply to everybody. So what we always feel is, oh, acha ye hota hoga statistics mein, mere patient ko nahi hoga. If I do a presbyopic lens exchange for a 40-year-old who is like -13, we know they are at higher risk for detachment, but then we always believe, oh, my patient won't get this. So then this 2% is not applicable to everybody you see, right? So what is the number in 95% of the people that you will see? So it varies from say 1.9 to say 3.5% or something like that, right? So that confidence interval at each time point is also really important, can also be depicted in these Kaplan-Meier curves, which has actually not been done. So a couple of these points I think were very important from a study design point of view. Another thing is, so why Kaplan-Meier curves are used and why all this is used, just for the uninitiated to understand is, we're talking about outcomes, which is a binary outcome. This is a yes, no, right? Our retinal detachment, hua ya nahi hua, did it happen or not? So it's a yes, no. When you have this yes, no outcomes, there are several statistical options which are available. Usually people will look at odds ratios. What are the odds of retinal detachment happening? 3 times higher, 4 times higher. But then when time is important, that time to onset is important, like in this case, or typically in 5-year survival rates for cancer or something like that, what we use is this time bound assessment. So this time bound assessment of a binary outcome is called survival analysis, right? And how we show it is Kaplan-Meier curves like this. How we test for differences is something called log rank test, which is like a t-test, but for this time bound kind of percentage differences. And lastly, how we look at odds ratio is, now here we call them hazards ratios. So this is it's a Cox proportional hazards ratios. So that's a little bit of understanding from a statistical point of view. Now, from a clinical point of view, I think what this study is clearly showing is that, the younger people we operate and more myopic they are, and the higher chances of retinal detachment. I think we pretty much know these things. Most surgeons would know these things, right? And we have a heart-to-heart conversation with our patients, before we offer these kind of, procedures to younger and younger patients, right? So, and we all feel that, oh, my patient is not going to get this, right? But then we need to explain that there is a 3-4%, 5% chance of getting. And I think most of us do that in our practices. Of course, if complications and other things happen, it's an entirely different scenario. But then, these things do happen. And lastly, I think, like Nazimul sir was already saying, and I think this discussion has already happened, that it's all driven by the posterior vitreous. So younger people don't have PVD when they have cataract surgery. And then when they develop PVD, if you just look at RD, these are the numbers. If you look at tears without an RD, which is also part of this whole process, you will probably see a doubling of these numbers, doubling of these numbers, because, a lot of people come to us before they get detachment. So,
I want to ask you one question.
Go ahead, sir.
Yeah. So suppose they would have designed this study, and from the registry, they would have extracted the cohort between 3 years. And then if they would have followed up the last cohort, which is, put in the study, and for next 5 years, if they have followed and look at that, those patients, okay, probably you would have answered more effectively.
Yes, definitely.
Yeah, your survival analysis would have been much higher and better.
Definitely. And I think we would have seen higher numbers also. Because if you follow them for longer periods of time, you are likely to get more detachments. So yeah, so what is the minimum duration of follow-up which is necessary for somebody to be included in the study is something which has not been given, right? Don't you see that's like a very large hole, right? Especially when you're looking at retrospective studies, then that becomes really important. So if you are taking somebody who's just a very high myope, who's 40-year-old and has been followed up for 3 months, and somebody who's 70-year-old and who's followed up for 4 years, because very large numbers, we don't know the sub distributions, how and what happened. So overall, these numbers at risk in that graph would have really told us, a lot of the picture, but then that has not been given. So it's a little bit of critique in the way the data is presented and also the study design. So minimum at least 3 years follow-up or 4 years follow-up, if they would have said, no, this really makes sense. But, we should now understand that these numbers are potentially higher than what the study is saying.
Unmute, sir.
You are also right. If the confidence interval of each point is so wide, then you will not be able to validate that value. If it's more narrower, probably the value of that result is
Dr.
more.
VC Mehta would now comment. Sir, please.
Oh, sorry everyone for the glitch up. But as very rightly said by Shail and Nazimul, that the main culprit is the posterior vitreous detachment. And this usually happens during the procedure when there is a lot of fluctuation of the anterior chamber. So when I pick up a young patient of a high myope, I see to it that I do not shallow the chamber at any point of time in my surgery. This usually happens when you change your hands, when you are doing a bimanual cortical cleanup, or when the phaco probe comes out. So before you withdraw the phaco probe or before you change the bimanual sides, then you top it up with the viscoelastic, make the chamber deep, and then do the surgery. A lot has been said about the pre-op examination, but quite often the pre-op examination may be difficult in a cortical cataract. So what is very important, as Shail has pointed out, is the post-op retinal checkup. And not only the immediate post-op period, but for a late post-op period. And the other culprit in a high myope with a retinal pseudophakic retinal detachment is the YAG laser. So in a young patient, he's more likely to get a POICO, and therefore he gets into YAG laser situation. So my protocol in a high myope patient who undergoes YAG laser is to give as many less shots as possible. So typically with my machine, I just give about 3 shots, and whatever opening habit takes place is fine. And then I call them after a week or so. So it's kind of a staggered YAG laser treatment so that the disturbances in the vitreous are less and the PVD also happens less likely. And in spite of all this, the high myope patient is very likely to get a detachment, and you should be very, very careful and advising them for a lifelong follow. I mean, that's what I can contribute to the discussion.
Thank you, sir. Basically, this is a open question to all the panelists who do a high volume cataract surgery. So, in the era of refractive cataract surgery, probably if this would be a webinar which would be talking on different options for presbyopic correction, no one would talk about retinal detachment in a high myope. So I just want to ask, when you counsel your patients for, a cataract surgery or prelex, do you actually counsel them heavily regarding the risk of retinal detachment? Because I think, in a busy practice, most surgeons, may avoid this. So what should be the right protocol to counsel the patient for the risk of retinal detachment in a myope or even not in a myope, in just a general population?
So I think if I can go first, I'm a little sort of extremist. I don't advise clear lens extraction for high myopes as a refractive procedure. So there are many who come in their 40s. I've been told, and this is an option. So we thought, let's get cataract surgery done at this place rather than that place, so on and so forth. And I tell them that for you, there is no good option for refractive surgery, because whatever the options are, the lens removal have a very high chance of you developing retinal complications post-operatively. So as a routine or as a rule, I never do high myope clear lens extraction, however much the patient is desperate. If he goes somewhere else and somebody operates, it's his luck. But at least you did, or we give whatever the advice that you think is in the right mind. And for any high myope, usually high myopes are the ones who develop cataract at a younger age, in their 40s and 50s. And therefore, we make it as a rule that, all of us know that in spite of doing everything, they may still develop a retinal detachment. But at least we must give that impression to the patient that we have explained to them and we have done all that could possibly have been done. So we always get the peripheral retinal examination done by a retinal surgeon pre-cataract surgery and 4 to 8 weeks post-cataract surgery, and ask them that, you must follow the retinal surgeon's advice and follow up with him for as many times as he calls you for a peripheral retinal evaluation, because such a thing can happen. Now, it can happen that the retinal surgeon saw it just today evening and tomorrow morning he may develop a break and an RD. But at least you did whatever the best you could. And because multiple people have counseled the patients, I have counseled him, the retinal surgeon has counseled him pre-surgery, post-surgery, at least when such a thing happens, they at least feel, although they will still be unhappy, but still at least they know that multiple people had told us at multiple time points, and they at least, were trying to see if such a thing happens or not. So that's something that I like to follow.
Vaishal sir, your take on this? Or talking to the patient pre-operatively regarding risk of retinal detachment?
I second completely what Sahil said, that I am a guy who does not believe into presbyopic lens exchange. I would prefer an ICL or a monovision ICL, something of that sort, especially in high myopes. I have done this thing, refractive lens exchange for high hypermetropes, a nanophthalmic eye or something. There, the whole ball game is totally different. There, even when you are doing a presbyopic lens exchange in a high hyperope, you are also preventing glaucoma in those cases where the lens is really thick, like especially in a nanophthalmic eye. But in a high myope, out of question. I would not think of doing a clear lens exchange before 55 years of age, for sure.
Parul ma'am, you're on mute.
Yeah, Neeraj, next question, sir. Dr. Mehta sir also, I think he's not commented.
We have Dr. Mehta sir's comment on this question, and then we can go to the next question.
Yeah, sure.
Yeah, I think everything has been covered up very nicely. The take-home message should be that high myopes should not be treated lightly, and especially the retinal detachment aspect of the whole thing. First of all, I take up the patient for a clear lens extraction only and only if the eye trace examination shows that the internal lens is at fault. So you have reason enough for the lens to be taken out, and then setting up a protocol in your own practice for the post-op retinal examinations repeatedly is the way to go forward.
Great.
So first you need to identify that yes, there is a need for the lens to come out.
Dr. Bide, do you want to add?
Yeah, actually, I fully agree with what Dr. Shail has said, and I don't do clear lens extraction for high myopes. And retinal evaluation is a must. So take-home message is a must. Retinal evaluation in high myopes.
Right.
And very good selection of the article. It's very useful for everybody. So congratulations to Dr. Charuta madam also, and to the student for great. Yeah.
Sir, I have one question to ask. Now that we are talking about retinal examination and the periphery, for a general ophthalmologist, what are those lesions that should be treated beforehand if the patient is undergoing a cataract surgery? A young patient is undergoing cataract surgery. Do we laser all the lattices? Just any opinions from our retina specialist over here?
Nazimul.
Oh, okay. I'm the only one.
Yeah.
And Sen Gupta sir also can comment. on this.
Yeah.
Gupta, sorry.
Yeah. Sabchai will be more with new knowledges. Okay, so I just want to make a comment before I go into your question. So me as leading the team, it becomes very important for my team where I've got 6 cataract surgeons. Putting what Dr. Vaisal has said, that you need a clinical practice guidelines. So I have clinical practice guidelines for every disease and surgeries. And the cataract is now, since we have got for cataract, but after this discussion, then I just fall back. I was thinking about my colleagues that I see many of them are doing for near vision correction and doesn't want to wear glasses because here the population is such, they are more into refractive than actually having a cataract, okay? Even if they have -1, they don't want to wear glasses. And they need a reading glass, they don't want to wear glasses, okay? So some of the things are cropping up. So here the practice guideline has become very important. So I have started a quality assessment audit on all these patients to understand that, to come to a conclusion, to give it to my team. I think all of us should have their own practice guideline and follow whoever colleagues comes to your hospital to operate. So you follow the same. And about the question of having a peripheral lesion in the retina, suppose you have a lattice degeneration and you have a cataract and you don't have a posterior vitreous detachment, or you have a posterior vitreous detachment. Yes, if you have a posterior vitreous detachment, you have a lattice, then yes, there is an immediate risk, okay? Because the gel is moving, then it can put a traction immediate. But if it's the intact gel, probably no, but you must address that immediately after, okay? However, what we will suggest, if you have a cortical cataract, then it becomes difficult to even laser those lesions, okay? And if there is a family history of retinal detachment, or the other eye had retinal tear, or the other eye had retinal detachment, then definitely you have to treat. But you have to understand the lens, how it's causing the blurring in the periphery. And if you are so damn necessary to treat, then you might have to cryo it, which we don't like it, because nowadays we don't want to traumatize the eye. We want, even in retinal surgery, we want a white eye post-surgery, okay? You can address this lesion post-cataract surgery. Immediately within a week or 10 days, you can do an indirect laser, okay? Unless if there is a hole with a horseshoe tear, definitely you have to address that before. You can use any method. We have got several methods. Now you have got diopexy, just like a cryoprobe, or you can use a cryo, or if you can depress and do the bring it clear zone and do the laser. Okay, so you have to individualize the patient. Okay, but the another thing I want to say, what is important is the counseling of patient post cataract. That is more important. Doing the surgery, you guys will do a wonderful job. Patient will be happy the first day. What is important is that guy, if he has a risk, you need to follow up. If you see, most of retinal detachments occurs within 7 months to 2 years. Okay, and so that is the crucial period. So the take-home message for those patients is making them aware. What are the signs and symptoms of retinal detachment? What is the importance of floaters and flashes? So that they come to the clinic, immediately they see something significantly different than what they are seeing, then you can treat it immediate and prevent a detachment. And that is very, very important, not to stop the checkup after 1 month. And you raised the question again, I heard that you do today the checkup of your retina and next day the tear happened. And that's how it comes. And there is the importance of counseling the patient. It happened with me many times. So I see it, then after 2 weeks later, patient comes, a lot of floaters, there is tear. But what is the difference? We made the patient understand, gave information leaflets on floaters and flashes. So patient understand the value. That's how you bring back the patient to your clinic, not to ignore that symptom. Thank you.
Dr. Gupta? Dr.
Yeah,
Sen,
so, it's lattice and non-lattice. I think that's how I actually look at it. If it's not lattice, if it's nail track or it's, some cobblestone lesions and something else, generally they don't cause much problems. If it's a lattice, then depressing and seeing that becomes really important, because sometimes there is subtle fluid, sometimes there are tears, which, so if you have a paper and there's a very small nick in one side, you won't see it unless you उसको छेड़ोगे नहीं तो नहीं दिखेगा, something like that. That's what I tell the patient, that I'm going to depress because I want to see what's in there. So if there is any loss of continuity, could be a hole, could be a tear, could be whatever, then I definitely go ahead and laser it. And most of the times I err towards lasering it if I can see it. So if and indirect lasers, most of the things you can actually do it. You can do a pretty good job. So of course, unless there is a lot of cortical cataract, but then if there is a lattice, then I generally tend to laser it. And more so if there are other things that Nazimul sir has already told us, there is other risk of family history of retinal detachment, or something has happened in the other eye. But then I generally, and if you ask most colleagues, they'll tend to err towards doing that, because the risk is very little of anything going wrong during a barrage laser. But then if you don't do it, there is a risk of detachment. So then if at least that's generally my approach, and most of people in my age group, I think we have a consensus that we generally do this. However, there's no hard and fast kind of rule where that you have to do it. But then better to be safe than sorry and it actually does prevent. I have done for one patient he has developed a tear in another part of the eye, and the only part which was attached was where I had barraged, something like that. So it definitely does prevent.
For us, Sabasi, you told the right thing. For us, there is the other aspect. These are real life aspect of legality. Litigations and legality. So if you have seen a lattice degeneration, and if somebody says, okay, you do the cataract, you have no risk. But if it develops a retinal detachment, there comes the problem. So I think discussion and counseling, that we need to treat it. But if you don't do the cataract, your risk of retinal detachment is very low. But if you do the cataract, your retinal detachment, increases by 4-fold. So we try to treat it. So if the patient understands, then it's fine. And if somebody ignores that discussion and later on had retinal detachment, we here get legal notice. So these are some practical things which have, when you discuss, that's how you bring the paper knowledge to a practical information. You cannot copycat. So this is how we derive information from numbers and studies.
Right. Also, a lot of people, a lot of cataracts send their patients to me for a retinal evaluation, saying that there's a young myope and I'm looking at presbyopic lens exchange. Is that okay? So if I don't see any lesions in the periphery, then I'm actually quite all right for them to go ahead with it. But then if there are lesions, and even if I'm barraging that lesion or not, it's probably not a good idea to go ahead with it. It's just a subgrouping sort of thing, which you would actually think about. So if there are no peripheral lesions at all, even if the patient is -12, -15, so then it's probably all right to, I don't think the risk is as good as anyone else who is not a myope. The risk still remains higher, but still that subgroup is probably, a little bit on the safer side. But then if somebody has a lot of lattices and other things in the periphery, then definitely, any cataract surgery is not a good idea. But if they don't have any lesions, it's probably okay to take that risk after discussing with them.
Absolutely.
Even if they don't have a lesion, just to continue the same thread, if that person develops a PCO, the moment you do a YAG, the risk escalates still further. So that is something which presbyopic lens exchange should be avoided. That is the whole point.
I don't know if Sabyaji can tell me, because for last few years I'm not studying much, but just reviewing. So is there any study to corroborate the YAG laser capsulotomy in eyes more than -6 diopter and retinal detachment? Because by the time these patients, more than 55 years, the vitreous gel is usually very high myope, do not have peripheral lesions. So it's actually, I feel very safe. Okay. So is there any study available?
So I don't think that YAG laser per se increases the risk of detachment, but then it ruptures the anterior vitreous phase because we almost can't see it. So
no, in a high myope.
So I don't think so that it can't be really teased out. When we are doing the analysis, we can't actually tease out that, despite being a high myope, does the risk of YAG laser increase the risk further? It's something becomes very difficult to tease out when analyzing data sets. So, I think it's a little bit, there's a lot of overlap is what I'm trying to say.
Yeah.
In call it interactive terms. There's a lot of interaction between these two risk factors. Now, which is more and which is less is something which becomes very difficult to sort of tease out.
I think it's an individual call.
Clinically, this is what we have seen.
Yeah, possible.
With the YAG, it has increased.
I have a very basic question, Nazimul. How do you really clinically, you can evaluate a partially detached vitreous or a fully detached vitreous on a clinical basis? Leave aside your B scan and your OCT. For a general ophthalmologist like me, I just know that there are vitreous degenerative stands, which I see in the anterior vitreous, when I'm doing a slit lamp biomicroscopy, and some ring which I'm seeing. So does it mean that I should consider that this patient has had a PVD? I'm so sorry.
No. So it depends on the various age group you are seeing. Okay. So if you are seeing a 60-year-old guy or more than 65-year-old guy, and you can see the ring, but for general ophthalmology, it becomes very difficult for me to explain. But how I see it, I do a very good slit lamp biomicroscopy. Okay, I love it. And I make my slits, I see the gel, I see if I can see any waist ring which has crumpled and become like a streak and is wobbling, moving. That means the posterior separation has happened. But that's not the point. That may be a partial detachment. Okay, you do not. So you have to check with indirect ophthalmoscopy. With practice, probably you will know that. Importantly, in myopes, in high myopes, the vitreous gels are firmly adherent from the equator. And that is how we perceive when we operate on them. Okay. So vitreous gel will be attached there. Now, if you see a non-myope cataract or non-cataract, and you'll be able to see the gel where it stops moving. But with practice, you will know. Okay. But now OCT has changed our mindset. Okay, so we are in a hurry. So because it gives us easy information within few seconds. So that is why I said that in all eyes that patient comes to you, even for routine check, we perform OCT to study the posterior vitreous phase and the vitreoretinal interface. And because these patients, most of the anterior segment, they do cataract, so they don't, they document this when they refer to me. So I think it's good idea always to do that when you have a tool there. And if they don't do a good indirect, at least take an ultra wide field picture with steering, not the single one, but steering the focus point up, down, right, left, then you can see up to the extreme periphery. If they don't have time, because I may not have time to see, but they will be able to screen at least with a confidence of 90% that there is nothing. Okay. So these are tools you can all use it to your use. Otherwise, it will be just like taking fundus picture.
I just wanted to quickly add, so when you look at slit lamp in a young patient, you will see it's like there is like sheen right on it, so
Yes.
they're shiny. So that is when vitreous is entirely attached on the surface of the retina, you will see like a sheen.
Yeah.
But then in older patients, that sheen is less and less seen. So then even till 40 45 you will see sort of, so if you just till the 90D or 78D little bit, you will start seeing that it's glowing. So then the light gets reflected back, so then there is no PVT there. But then if you are so it's more helpful with the 20D because it's larger, and if you can, so we depress it and then we sort of tilt the lens, and then you can see that sheen. And it's good to see the vortex veins, because the vortex veins really tell us whether there is it's a anterior or so that basically
that's
marks
equatorial. Yeah.
the equatorial pre-equatorial, so whether the PVD has gone beyond the equator or not. And like in myopes, like sir has already said, most of the times that sheen is there in the periphery. That means the the peripheral vitreous is still attached, or the vitreous base is larger. So even if you see a Wise ring, that it's not 100% sure that peripheral vitreous is still completely off the retinal surface. So also, it takes a lot of practice. Even, when we are training and when we are doing surgery as young retinal surgeons, seeing the posterior hyaloid is difficult. Even during surgery, when you can touch it, when you can pull it, it still becomes difficult. So people use triamcinolone and chromovitrectomy and whatever. So it is not easy at all. There's a lot of practice. But then, for youngsters, looking at the peripheral retina and then sort of tilting your lens, that actually helps. If you see that sheen, that means there is vitreous there. If you don't see the sheen, then perhaps the vitreous is separate from the retinal surface.
Yeah, I think there is one more information, because we see a lot of young myopes. Our colleagues does cataract surgeries, but some of them may be sticklers. Okay, some of them may have other vitreoretinal degenerations. You will find optically empty vitreous. So it will be very, very difficult. So you do your job and ask the retina specialist to take care of that. So basically you have to address the vitreous and do a proper check, and that is what I think all the discussions which we had this, and understand every lesion, which one weighs the proportion of importance, and just if you cannot show to retina specialist, if you have an ultra wide field fundus camera, then try to take up and down, right, left, and see all the screen, all the periphery, and that will give you the confidence to operate, that there is nothing. At least save you from if there is any problem in the future.
Yeah, Mehta sir, you want to say something?
Yeah, Dr. Mehta sir. Final comments from all the panelists.
Yeah.
Yeah, I think the myopes should not be taken up for a cataract surgery very lightly, even if the cataract surgery is indicated, and retinal examination has to be done. It will save not only clinically preventing a detachment, but also legally you will be very safe. And we do take the fundus photography for the pre-op and post-op in a high myop patients, and giving them the leaflet of what looks like vitreous floaters and photopsia should be kind of ingrained into their brain, that in case such a thing happens, immediately call us and come for a checkup.
Dr. Shail?
Yeah, I think the most important point is counseling the patients that cataract surgery is not the end of the story for you as far as your eye surgery goes. Because you may feel that, many of your parents, your relatives, they had cataract surgery, they never followed up after 1 week ever to their ophthalmologist. But you are different, your eye is different, and therefore for you, follow up lifelong, and particularly in the first 6 months or a year or two, is very important from the retinal perspective, that in spite of our best cataract surgery, the best lens in the world, the best femtosecond laser technology, you can still end up with this complication for which you need to keep getting examined time and again.
I think we have come to the end of the session because we are short almost 7 minutes above time. And I thank the faculty. It was a brilliant discussion and a very basic topic. And day to day, every one of us are affected and address this problem. So thank you so much, Dr. Sahil Vasavda, Dr. Nazimul Hussain, Dr. VC Mehta, Dr. Sabyasachi, and Dr. Charuta Mandke, and Dr. Monica. So I would ask Dr. Anaga. Anaga, are you there? Fine.
Yeah, she's there.
Okay.
Should I call?
Fine. So,
She's there actually.
and I
But
can't
very
see her
good
now.
discussion actually. It was a very good topic and an excellent discussion and lots of important message for the.
So thank you, Zen, for and Dr. Neeraj for putting a brilliant effort to carve out a good journal club meeting today. And thanks for selecting this topic. It was Dr. Zen who had selected and Dr. Neeraj who had selected this topic for this meeting. Though it was a slightly older topic, in 2015 it was published, we were slightly skeptical about it. But nevertheless, and I would ask Dr. Zen Khatib to do the Thanksgiving.
Thank you one and all. Thanks to all our panelists, the members of MOS and BOA, Dr. Charuta ma'am, Dr. Monica. Thank you. It was a very informative and good session. And hopefully we will continue, churning out good topics for journal clubs every 2 months under this program.
18th October is the next journal club meeting. 18th October. It's a Wednesday.
Yeah.
MOS is around that time only, no, sir? No.
MOS is after 10 days.
Yeah, after 10 days. So that will be the last journal club meeting.
Yeah, and we thank Entod for their technical support and all the support they have extended towards this meeting. Thank you so much, everyone. Thank you.
Thank you, everyone. Thank you, Mehta sir. And
yeah, Anaga, I just wanted you to do the Thanksgiving.
Yeah, she has joined for Thanksgiving. Actually.
Yeah.
Over to you, Dr. Anaga. You can unmute. But it was a very good discussion and lots of messages.
Just a point for all the attendees, the certificate option is now, there's a tag on your link, the same link which you joined now. There is a yellow color tab which you can click and download your certificates respectively.
Great.
She has not unmuted.
Rahul, you can put the certificate on the screen now.
Yeah.
I think Anaga ma'am is in a
Anaga
low
is
network
traveling.
zone. Yeah.
Then she's traveling. Yeah, traveling just now.
Thank you, everyone. Thank you.
Thank you.
Sorry, I'm traveling. I don't know.
Yeah. It's okay.
Sorry. Thank you.
Yeah,
Thank you to all the panelists. Thank you. Dr. Shail, Dr. VC Mehta, sir, Dr. Vaishal, Dr. Parul, Dr. Charuta, Dr. Neeraj, Dr. Zen.
Good.
Fine.
Thank you. Thank you, everyone.
Thank you.
Good night.
Thank you, Shrail, and thank you, Nazamul sir.
Yeah, thank you.
Thank
Thank
you,
you.
Dr.
I
Moon.
really liked it
Thank you,
after a
Nidhavan,
long
sir.
time. Seeing you all.
We enjoyed your comments, Nazimul.
Thank you. Thank you.
Yeah. Thanks. Good night.
Bye.
Thank you. Good
Good
night,
night.
everybody.
Okay.
Very good presentation.